All right, everybody, if y'all want to have a seat, we still have a few up here and are rounding out with a very good discussion on breast cancer. And I'm super excited to have our guest today. So thank you both for being here. First, we have Dr. Stephanie Graff, who is the Director of Breast Oncology at Brown University Health and Associate Professor of Medicine at Brown. And we have Dr. Maryam Lustberg, who is the Director of the Breast Center at SMILO, correct? SMILO Cancer Hospital and Chief of Breast Medical Oncology at Yale Cancer Center. So we're going to be able to discuss some very interesting stuff. And anything you all want to discuss off the cuff, please feel free to do so. So with that said, I think hopefully there was a big thing last year about, are people comfortable with antibody-drug conjugates? And you know, some people stating they're not familiar, but a lot of stuff that's come out this year and in the past year or two on ADCs as well as emerging targets. So when we think about, you know, one of the first places that I think commonly through the community people considered this was expanding into HER2-Low and now this, you know, classification of ultralow from Destiny Breast 06 all the way to 11, right? Yeah, 11 with trastuzumab deruxtecan. Tell us, if you can, how that's evolved, what we're excited about, the challenges of really redefining how we thought about HER2 as a binary positive or negative thing, and all of a sudden we have to go back, you know, to the path reports from a couple of years ago and see if it matters or rebiopsy. How is that all kind of filling out, and what are patients seeing as far as benefit goes?
So it's really interesting. It's been fascinating watching how the HER2 story has been changing over time. So going back a little bit to Destiny 04, which looked at trastuzumab deruxtecan for this HER2-low population, kind of a little bit later line than Destiny 06. Yeah, so I think what I've been most fascinated with is just the impressive activity of trastuzumab deruxtecan, just with a little bit of signal. And as you mentioned, yes, going back to path reports, because a good proportion of the patients in both 04 and 06, this HER2-low finding goes all the way back to even primary tumors. Yeah. So it doesn't even have to be their metastatic tissue. So I think it has absolutely expanded options, but has also raised the questions about just the limitations of antibody HER2 testing. So this is an area that has been discussed quite extensively in that, you know, our old ways of doing antibody testing for HER2 may not be always reliable. Pathologists can disagree. So there's a whole body of research around better quantification. But even using these old imperfect methods, we're definitely seeing tremendous efficacy. So I'm happy that I have this option for my patients.
I think that, you know, the other thing that Destiny Breast 04 and Destiny Breast 06 brought into the landscape is really trying to figure out what those trials means in terms of sequencing. So both trials are more heavily in patients that are hormone receptor positive. Destiny Breast 04 did include a small proportion of patients that were triple negative. So we do have approval for HER2-low patients that are triple negative. Destiny Breast 06 only included hormone receptor positive patients and had that ultra-low indication. And so in the Destiny Breast 06 trial, it moved it into the first-line chemotherapy. But with metastatic breast cancer, first-line chemotherapy should be second or third or fourth line therapy, depending on what targeted agents you have. And my worry as a breast oncologist is that people are going to want to jump to that too soon because they saw some splashy podium presentation at ASCO, or they saw a fancy billboard in the airport at O'Hare. And don't do that. I think that the oral therapies that we have really give our patients fantastic quality of life. And it matters to our patients not to be tied to the infusion chair. And so, you know, I still reserve trastuzumab deruxtecan for later lines of therapy. And I still engage my patient in shared decision-making about if we want to use trastuzumab deruxtecan, Destiny Breast 06, as our first chemotherapy, or if they would rather do capecitabine. I do recognize that Destiny Breast 06 is going to meet its overall survival endpoint, but the median progression-free survival on Destiny Breast 06 and the median overall survival on Destiny Breast 04 are about the same amount of time. So it seems like it doesn't matter when you get trastuzumab deruxtecan, you're going to get about the same benefit from it. And so if your benefit is going to be the same magnitude, whether it's your first cytotoxic or your second cytotoxic, and if, you know, I practice in Rhode Island, loads of my patients in Rhode Island secretly live in Florida half the year. And for them to like be bound to Rhode Island where they're getting infusions every 3 weeks rather than be able to sneak off to Florida and take their oral capecitabine is a huge deal for them. And so, engaging the patients in that shared decision making remains really relevant.
Yes.
No, I think you bring up some excellent points, and one that I kept wanting to make earlier and didn't, but there's this thought that initially you think about treatment lines as additive on benefit, like on survival or progression-free survival. And then sometimes it's actually where it's more than additive. So 2 + 2 = 5 or 6. But in this case, you want to consider, does 2 + 2 = 4 or does it equal 6? And that can help that kind of judgment.
Yeah, and
there are patients where I think an earlier introduction of ADC would make sense if they're showing early endocrine resistance. But I agree. I mean, a patient who is relatively stable with bone-only disease and you have used your endocrine therapy, targeted therapy options, I think that shared decision-making is a really good starting point. Many patients prefer oral therapy, but I've also heard from patient advocates that don't assume that necessarily, that some patients really would like to come in and go in and out and take an IV infusion. So like you said, it's a discussion.
Yeah.
Anything else?
I secretly want like the Sonia trial, which was CDK4/6 inhibitors first versus second, that was done outside of the US. We didn't enact that as a changing trial in the US because the control arm was fulvestrant, or the switch therapy, the PFS2 agent was fulvestrant, and we don't really use fulvestrant as our standard of care in the US. But I want the Sonia trial for Destiny Breast 06 and Destiny Breast 04, right? Like I want to know, well, what happens if everybody crossed over, and what happened if everybody got that in the second line, first line versus second line, and what that would look like. But realistically, I'm never going to get that. So we're stuck where we are.
Well, AI might be able to go backwards and do a little analysis.
Yeah.
Dare to dream. So to that same point, well, I will say as an asterisk, one thing I didn't appreciate until after all of this HER2-low and ultra-low is really the community aspect of identification, especially like through social media. I learned that a lot of patients, at first I thought it was in jest, but it actually kind of caused like a problematic identity crisis because there's this community around triple negative breast cancer, and like, we have the ones where we don't have targets, and then all of a sudden a proportion of them had turned out targeted therapy, and it led to this kind of weird identity issue almost because these support groups are so strong, even subclassified into their hormone type. So I don't know if you see that, but it's something that anyone with patients is just to be sensitive about, because especially in the stage 4 setting, I mean, like there's a lot of pride and identity behind those things.
But I think kind of education around HER2-low, I think there's been a lot of confusion about it. So I think kind of like you said, kind of being aware that of past reports that can go way back, and then there is now 2 studies that will be specifically looking at even HER2-0. We had the DAISY study from way back where it showed that even patients with IHC 0 could potentially true nulls. We have the Paradigm study that we're going to open in Yale, Emory, and Rutgers pretty soon. We're strictly looking at the 0 population and then further quantifying the HER2 signal. And then TRADE-DXd is a large study, which is now, it started out as a HER2-low study to look at the sequencing of ADCs. It's going to look at 2 trope ADCs. So patients who are HER2-low or now even HER2-null or 0 will essentially get randomized to receive Dato-DXd or trastuzumab deruxtecan, and then at progression, they get the other ADC, and it's very much rich in correlative, so we can understand these resistance patterns. So these are 2 studies that are even kind of going beyond kind of the ultra-low and the HER2-low.
And I think TDXD is actually biomarker agnostic at this point, right? Like they don't have a biomarker. We're giving it to people who don't have the biomarker, and they're responding beautifully, right?
Yes.
So
that's pretty wild. That's a very good point.
Although, certainly the stronger the signal, I mean, the response rates tend to be higher and PFSs tend to be longer. But yes, I agree. It tends to be a very effective drug.
At least in breast cancer.
Yes.
It's kind of like PD-1 all over again
Yes.
from 2015 to now. And with that said, I guess a version of, the argument of Ohio State, Michigan, LSU, Bama, sacituzumab govitecan, right, in hormone receptor positive, HER2 negative, or triple negative breast cancer, TROPiCS-02. At one point I was telling, a company, I'm not gonna say which one, where they were like, well, how do we, have physicians thinking about using this, or why they wouldn't use the other one? I said, look, you want, ideally, any metastatic patient to get all of it. Like, you want, the whole purpose is to be able to see and survive well. How do you think about those as that choice, in what's classically or traditionally triple negative, is in consideration of what to use in that metastatic setting?
So things are shifting in that setting. So we had ASCENT-04 was presented in the oral metastatic breast session, and so clearly we are seeing a modest, strong advantage over the traditional Keynote 355 regimen compared to traditional chemo plus pembrolizumab. Sacituzumab plus pembro is showing an advantage, and so I think this will likely become our first-line setting. But until guidelines change, and you can probably get it approved likely. It was one of the questions in the oral session to Sarah Cellini, and so I think the guidelines will likely change, and there will be an indication for this in the first line more than likely. But before then, I think to your point, I was using traditional chemo immunotherapy first line, and then the second line setting, I think many of us have felt that given, as my colleague mentioned, in the DESTINY-04, the subset of patients with triple negative breast cancer were much smaller. We had the ASCENT study, which was strictly focused on triple negative breast cancer. At least in my practice, I was using sacituzumab as kind of the second line, unless there were, there were patients who I may selectively choose trastuzumab deruxtecan, but in general, I was using sacituzumab as second line, and likely that's going to move up to the first line now.
I think I'm less reticent than Dr. Lustberg in my interpretation of the ASCENT-04 trial. I think it is practice changing. I plan to start using it.
Do you think you'll have any trouble getting approval?
I don't think I will. I think that there'll be problems for some, but they're both commercially available agents. They're both approved. I think that we'll be able to utilize it. I actually know even before the data was approved that some of our colleagues have been able to get it, even after just the press release. So I think that for me, it's practice changing. It's a meaningful improvement. For me, I think that perhaps the biggest takeaway from ASCENT-04 is the tail on the curve. This is a first-line metastatic triple-negative trial, and when you look at the ASCENT-04 curve, there's this really long flat tail already emerging, which suggests that there may be a group of patients. There are de novo metastatic triple-negative breast cancer patients on that trial. We need longer-term follow-up. We need some additional data about who's in that flat part, but maybe there's a cohort of metastatic triple-negative breast cancer patients that are going to have a long-term durable disease-free survival. I don't know that I would go so far to say cured, but wouldn't that be great if as we emerge into this antibody-drug conjugate that we get those patients on that long-term curve? And the question will be what de-escalation looks like. Like at some point, do they get to drop the pembro or drop the SASI, and then what does that look like for those patients? We also have a positive press release for ASCENT-03. We didn't get the data at this ASCO. I assume we'll get it at the next big Congress, which is the same trial without the pembro in a PD-L1 negative population. So I think we're going to see SASI in the triple negative group up front. You have up here the TROPiCS-02 trial, which is in the hormone receptor positive patient population. TROPiCS-02 was after 2 lines of chemo, so a very heavily pretreated patient population. I feel like TROPiCS-02 is the trial everyone loves to hate, right? Like it was presented at the same ASCO where DESTINY-Breast04 was. So, Dr. Modi stood at plenary and got a standing ovation and wow, look at those curves. And then the next day we're all tired and Hope stands up and presents TROPiCS-02 and everybody's like, oh. But it improved overall survival in a heavily pre-treated,
Yes.
like second line and later chemo, which is for, again, hormone receptor positive, like fifth line and greater systemic therapy. Like, you don't get that in cancer. Like, you don't improve survival at fifth line therapy. So for hormone receptor positive breast cancer, I like to try to get them sacituzumab. And it's tricky because by the time you're at that line, you often have a patient who's feeling rough. And then you start telling them about what sacituzumab is going to be like. And they're like, man, Dr. Graff, what are you doing to me?
Mm-hmm. Yeah, I mean, I think in the hormone receptor positive population, most patients generally can get 2 ADCs. So I tried to, if they're HER2-low, they generally can get both. But I think in this triple negative population where I think really some of these patients, those of you who are treating this population, some of them are not even really getting to the second line. Their disease is so rapidly progressive. So I think part of why the earlier introduction of ADC in this population is so important is we want to give the better therapy sooner before they deteriorate. There are other exciting ADCs in this space. Sacituzumab formulated with a different linker and a slightly different payload. That's sacituzumab TMT. So the phase 2 study, which was OptiTROP-05, is a phase 2 study that read out, and there's now ongoing phase 3 study with this new ADC. And then we have TROPION-05, which is looking at darvolimab, Dato-DXd, which is another TROP2 ADC. So the TROP-05 is presenting a research dilemma because the comparator arm is likely going to be, the comparator arm is the old chemo backbone. So they are debating how to rescue that study right now. So I think things are changing so rapidly, but the good news is that these new treatments are increasingly becoming available for this population that is very much in need.
We don't need another versus bendamustine and non-Hodgkin's lymphoma kind of trial analysis. So with that said, with ADCs, trying to get them in sooner, get that cytoreduction, what are some of the ADCs that we're excited about when it comes to things like HER3, TROP2, well, TROP2 we talked about, and then B7H4, are they promising? Are they exciting?
I mean, I think ADCs that I'm excited about, the HER3 ADC is exciting. It's in phase 3, so I think we'll be seeing it finish accrual really quickly and move forward really quickly. I think Dato-DXd is actually an exciting drug. We have already seen Begonia, which was an earlier trial in the neoadjuvant setting, and combined with durvalumab, which is an immune checkpoint inhibitor. I don't know why I just explained that to you guys like you didn't know. I'm sorry, I did that. I take it back. I'm used to talking to breast oncologists, and they don't always know all the immune checkpoint inhibitors. We're late to the game.
We're late, but you're making up for it with all these different ways of using it.
We're trying. When you look at the objective response rates for Begonia compared to what we saw yesterday with Acento-4, I'm excited about the potential for TROPION-05. And then there's actually a new a bispecific HER2 ADC called zanidatamab that's in phase 3 trial now after trastuzumab deruxtecan. So right now on the commercial market, there is not a single ADC that's been shown effective after trastuzumab deruxtecan, which in my humble opinion is a problem because apparently we put it in the water now and give it to everybody with any cancer. Gone are the days when I could tell people that cancer wasn't cancer and we didn't treat it all the same, because apparently we do now. We just give everybody TDXD, right? Yeah. So
just so many exciting drugs. I mean, this is really a revolution. So also additional bispecific, there's at least 4 or 5 bispecific ADCs that are targeting VEGF and PDL concurrently, and they're being tested in triple negative. And they're smaller studies now, but when you look at the objective response rates, they're in the 50 to 70% range. So really exciting there. And then kind of vaccine-based, there's this BRIA IMT kind of vaccine allogenic study that's really promising. So lots of excitement in this area right now.
Anixa too. I mean, I'm an advisor for them. I think they have a HER2 if it's not a HER2 vaccine, it's actually the prolactin, and the thought that if you're postmenopausal, you stop making this protein that's related. So why would you could vaccinate it against people with previous breast cancer? It's just crazy. I'm just gonna throw this one out there as a wrench. What about possible ADCs and like neoadjuvant? Is that even on the horizon? Are we just saying, well, we already got the guidelines there, let's just not look at it?
So I think it's scaled response. I think right now we're looking at ADCs in a landscape of non-pathologic complete response. So we're trying to, we know that a pathologic complete response can be sort of a biomarker, if you will, for more biologically aggressive disease. So think to the Catherine sort of paradigm, where patients that get traditional therapies and don't have a pathologic complete response then can be randomized to something like TDM1 versus TDXD, TDM1 plus tecotinib versus TDM1. All of those things are actually metaccrual and we're waiting on results. But the same thing's going on in triple negative breast cancer. Right now, standard is capecitabine, but we have every trial with every ADC in that space competing. And then obviously that's the I-SPY design. So many of these therapeutics are being rolled through the I-SPY design, which is Laura Esserman's brainchild and is bringing drugs to the breast cancer oncology landscape really quickly. Are you an I-SPY investigator?
I am.
Yeah,
It's great. It's great. I-SPY is great, and it has led to identification of this ultra high mammoprint group of tumors with hormone receptor positive breast cancer, where kind of, the old saying that, hormone receptor positive breast cancer are cold tumors, they don't benefit from immunotherapy. So now there appears to be a subset of hormone receptor positive tumors that benefit from combination chemoimmunotherapy. So that's now a national SWOG randomized clinical trial. In terms of the neoadjuvant setting with ADCs, there's Tropion-04 that's wrapping up accrual, and that kind of focused on this kind of high risk population, kind of a HER2 positive ADC, triple negative with ADC plus immunotherapy. So definitely it's moving up to those earlier stages for sure, but mostly, I think the triple negative residual disease population is the highest need, and kind of incorporating ctDNA data in terms of better stratification of the system as these patients is also something that I think we're thinking about how to incorporate better biomarkers as we design future studies in this next phase. So this was the focus of the ctDNA symposium that just happened right before this.
Yeah.
Kind of like we need new clinical trial designs that are taking into account these dynamic biomarkers.
Yeah. I mean, we really need to contextualize and characterize the setting.
Yeah.
With what we're able to do today, rather than maybe a more obtuse bucket previously, where conclusions get diluted because you haven't partitioned it. Swinging the other direction, and this is one place where I think like parallel assessments with real world data, retrospective with AI tools. I mean, nothing genius other than just simply looking at what happened and what the longitudinal data was. Sequencing. So we talked about 2 + 2 = 4, but then we talked about unless the other 2's first and then you use the other 2, and now it's 6 because it actually matters if you use PARP inhibition right before immune therapy because it affects the lymphocytes, et cetera. How are y'all thinking about, I guess, for the purposes of ASCO, what has challenged the way or introduced something new about the way we think about sequencing in a metastatic setting? And what are you either optimistic about or hopeful of getting clarity on where otherwise has been kind of dealer's choice for a while? Which, of course, is always a balance of toxicity, tolerability, and how many lines you think you can get in. But is there anything new that excites you about the sequence of therapies that can potentially buy you longer shelf life?
I mean, if you guys missed Angie D. Michelle's discussion of Serena-6, you should watch it on live stream. She did just an amazing job discussing how complex Serena-6 is to consider. Like, I don't consider if camizestrant was approved commercially tomorrow, I don't think I would be ready to use it. I think I need longer term follow-up. I think I need to understand the crossover better. And I think Angie just perfectly said all the things I was thinking and feeling about that trial. And so I think that that's one space. I think that we understand that ctDNA is prognostic. We don't yet know if our ability to respond to it matters. And I think that there's other trials that have been conducted, like ANIVA 120, where, clearly it improves survival, but there's questions about the control arm and the lack of crossover that is also concerning. Again, I think that one of the strengths of the, wow, my ASCO brain is tired. One of the strengths of Ascent 04 is that they had crossover by design. The company provided sacituzumab to people. It may end up ultimately messing with the overall survival data. But isn't that great in a global culture where patients often don't get these drugs, that they were like, hey, if you do our trial, we're going to give you these drugs. So I think that there's a really, really messy breast cancer landscape right now that makes trial interpretation really hard to Monday morning quarterback.
Yeah. This second line post-CDK4/6 inhibitor, I'm sure you guys are struggling with that, and it's going to get extra complicated kind of. So what we can all do is acknowledge that we're in it with you and that nobody knows the answer. So we're going to have all these different agents in this space, and it's very hard to actually compare them. Much of the data is with single agent, and then they're going to have combination studies. So I think kind of taking into account kind of toxicity differences, patient experience on these drugs, I think it's going to be hard. And the value of good, robust, real-world data, I think, will become even more increasingly important, because we're not going to have direct comparison trials with many of these agents.
Exactly. Yeah. It's going to be a challenge. And it's almost like you almost don't want to form habits. Like you almost want to be anti-habits, just given how much can be uncovered in the kind of the different variations of these sequences and how they can be stacked. And but that's why it's very humbling to have both of you to guide us through all of this. Otherwise, ultimately, very exciting stuff when it comes to treatment paradigm. But certainly, I think some of the younger and general oncologists that can't be breast specialists are somewhat intimidated by getting it right, so to speak, to avoid moral injury and not saying like, should I have? So we appreciate y'all. Are there any really pressing questions, if y'all have time, for something we didn't cover? Or
so Dato-DXd is now approved, but are you using it after? Because everybody's getting in HER2 and Trodelvy, so then do you use it? Do you not use it?
I have not used it yet off trial. That's really complicated by the fact that I have a trial that has a very open indication, so I can kind of give it to anyone I want at any time on trial. So I'm not the right person to ask. How are you using it?
So just reminding everybody that the indication currently is only in hormone receptor positive metastatic breast cancer, as you're saying. So we also have a trial. We participate in the TRADE-DXd study, which is sequencing the two TREP2 ADCs. So I think kind of for that patient that is doing really well, I think some of these hormone receptor positive metastatic patients can go on to get a second or third ADC. I think that's somebody that I would maybe consider. It's not something that I've heavily used outside of a trial. It's a great question.
Excellent. Well, thank you all so much. We appreciate it.
Thank you.
And that concludes today's panel in rockstar fashion. So thank you all very much for your attendance and for doing the most.